Thank you very much. So the title is a little bit provocative, but that's okay because PK likes to mix it up. So I think we can all agree that lower extremity bypass has been the traditional gold standard for quite some time for long, complex fem-pop disease. But I think we have to be honest. We have to admit that there is high morbidity. There's higher mortality than endo, higher infection rates, longer hospital stays, longer recovery times. And although we're getting better and better every year with endovascular therapy, we also, on the endo side, have to fess up and admit that depending upon how long and size of vessels and runoffs, we can have up to 25% need for reintervention up to 1 year. So PTAB I introduced to you a little bit earlier, so I won't go through all the details. But the DETOUR trial is really what led to the device being approved in the US. And I think it's important to keep a couple things in mind when we look at the data. First of all, in order to get into the study, you had to have at least a 20 centimeter long lesion. Most of these were actually CTOs. And the diameters had to be 4.5 to 6.7 with an accessible SFA at the origin. The POP had to have a less than 50% stenosis with at least one good tibial vessel. And you had to have a patent femoral vein or a duplicate femoral vein. So I hope in the next couple of minutes to convince you that PTAB compared with open prosthetic bypass is less invasive, less expensive, with equivalent patency and durability, with obviously shorter length of stay and better quality of life for the patient in terms of less pain, fewer complications, and a faster recovery. So a quick review of the DETOUR studies. DETOUR 1 done in Europe, and DETOUR 2 was a much larger study done with core lab adjudication with the same primary safety and efficacy endpoints. If we look at the demographics, a high preponderance of lots of risk factors. Over 50% of patients had had a prior previous intervention. Almost all of these were CTOs. They were basically all task D lesions, ISR in 14%, with very long lesion lengths of about 32%. And if we look at the data, it's very respectable. A 58% primary patency at 3 years with a secondary patency of 96%. Freedom from TLR at 3 years was about 2/3 of the patients. Freedom from graft occlusion, 84%. And again, this is important, freedom from major amputation, 98.5% at 3 years. Well, what about the DVT? Yeah, there were a few DVTs. 6 out of the 7 resolved with anticoagulation alone. There were no PEs and no DVTs after the first year. So fem-pop bypass has been the traditional gold standard, but it's not without its risks. This was a nice review from Michelle Reinen's group in the Netherlands. Over 6,000 patients, 37% 30-day morbidity, 7.8% wound infection, 7.4% post-op bleeding, 12% were occluded by 30 days, and 2.3% 30-day mortality. This was an old study from Japan, but it was kind of interesting to compare task C and D lesions treated with basic endo, just PTA alone and 25% bare metal stents. And even though the primary patency rate was better with bypass surgery, secondary patency rates were the same. But if you look at the 30-day complications, significantly higher rates of emergency surgery, blood transfusions, wound infection, and MI. Well, what about the durability of prosthetics? So this was a randomized trial from Abbott et al. 3-year primary patency rate with PTFE was 57%. But as Dr. Bianchi kindly pointed out, the 3-year primary patency rate with PTAB was equivalent at 58%. This is the most recent large-scale meta-analysis summary that I could find on bypass surgery. And you can see that overall with PTFE, the 1-year primary patency rate was 70%. The 30-day event rates, though, still significant in terms of mortality, MI, major amputation, DVT, major bleeding, and infections. So if we look at PTAB compared to this large meta-analysis, we see that we basically have comparable patency rates, but with less morbidity, mortality, and a shorter length of stay. Other outcomes also were in favor of PTAB when you look at the risk of graft thrombosis, infection, length of stay, hospital costs, and the need for reintervention. So this is a case where I don't think we're going to get any disagreement, surgeons and interventionalists alike. This is not a patient that we really want to take to the lab. This was a gentleman with horrible COPD, diabetes, 2 different kinds of cancers, leg ulcers, ICD, hip and knee replacements, who had had 2 failed attempts at an outside hospital to traverse his right SFA CTO for his Rutherford 4 arrest pain. Not surprisingly, he was kindly declined by our vascular surgery colleagues, and you can see he's got a long SFA occlusion with reasonable runoff, with dense calcific disease, which I think you can appreciate on this unsubtracted view. This is seriously dense calcification. You're not going to be able to fix this with vessel prep and IVL. So in this particular case, the best way is to just go around it. So this was a case that we're able to treat with PTAB, and he went home the next day. So in summary, why I think PTAB should be preferred for long segment SFA disease versus open bypass. Well, it's minimally invasive. Reduced procedure time, hospital stay, cheaper, equivalent durability, comparable patency rates with less morbidity and mortality. Particularly, I think, ideally suited for patients who are old, have a lot of CAD, bad groins, obese, poor or absent venous conduit, in-stent restenosis, which I'll talk about a little bit later this afternoon, and it's particularly for patients who have just dense, severe underlying calcifications. And most importantly for the patient, it comes with less pain, faster recovery, and fewer complications. Thank you.